pH every hour for the next 2 to 8 hours. This urine should be freshly voided urine. And if the urine pH is less than 5.5, generally we don't do these tests nowadays, but the contraindication is you should not do these tests in severe acidosis. The serum bicarb is less than 17 milliequivalents per liter. And you should also check the urine sodium, because if the urine sodium is low, also the potassium will be low. And the second test is a furosemide fludrocortisone test, which we do, which some of the pediatricians prefer to do these tests. Wherein you give after an overnight fast, first morning pH is checked, and furosemide is given at 1 mg per kg and fludrocortisone at 0.025 mg per kg. And urine pH is checked hourly at 4 to 6 hours, and urine pH of less than 5.5 indicates a distal acidification defect. Here also the potassium should be normal. So this is regarding the distal RTA. When you suspect acidification defect, we do these tests. Suppose you suspect proximal RTA, that is bicarbonate loading test, we do where we check for the fractional excretion of bicarbonate. Sodium bicarbonate is given at 0.5 milliequivalents per kg at the rate of 3 ml per minute. And we check the urinary pH at 30 to 60 minutes interval, and it is more than 6.5. The fractional excretion usually is less than 5%. As we all know, 85% of the bicarbonate filtered is absorbed in the proximal tubule, and the remaining 10% is absorbed in the distal and thick ascending limb of fluid. If the fractional excretion is more than 15%, that means there is bicarbonate wasting, and the possibility of proximal renal tubular acidosis is high on the cards. And as I told you, proximal RTA is a generalized wasting disorder. So we also see the other excretion factors like phosphate is more than 15%, and urinary calcium creatinine ratio is more than 0.2, and the 24 hours urinary calcium excretion is more than 4 mg per kg per day. And hypocytiaturia is also documented in these patients. And the most important thing is ultrasound examination should be done for all the patients. Though they have a normal renal function, we should check and look for kidney stones, at least nephrocalcinosis. And sometimes as adult nephrologist, we go in vitro because patients come with nephrocalcinosis, and we have to work in vitro for the estimate of RTAs. And evaluation of extrarenal manifestations would help in identifying the etiologies, especially in proximal renal tubular diseases where there are multiple syndromes like cystinosis, Lovick syndrome. In cystinosis, especially, the patients can have eye corneal deposits of the cystine crystals, and in Lovick syndrome, it's ocular cerebral disease. There are multiple abnormalities. Dysmorphism is present, and I suggest, out of this talk, if you want to pick up something, that any child with the deformities, please do their hearing assessment as well. Hearing assessment, ophthalmology examination, they do pay you a lot in the long-term management of these patients, not only in the etiology. So always assessment of hearing must be done in all children with distal RTAs. So how do you differentiate between proximal RTA and distal RTA? There's a big table, but to remember, most important is the bone deformities are very severe in distal RTAs, and the acidosis is also severe in distal RTAs, but it is easy to correct with bicarbonate supplementation. So this we can see only once we started the patient on treatment, we can assess this. And as I told you, distal is always acidification defect. So the urinary pH is always alkaline, and the bicarbonate excretion is more in the proximal RTAs. And these are the causes, which are the hereditary causes. So I'm not going into detail of these causes, but most of the times distal RTAs are hereditary in children. The most common is autosomal recessive form, which is because of the defect in the anion exchanger. Autosomal H plus ATPase. H plus ATPase is common, followed by anion exchanger. And proximal RTA cystinosis is one of the common diseases, followed by dense, Fanconi Bickel, galactosemia. I'm sorry. And hereditary fructose intolerance, Lovick, tyrosinemia. Wilson's disease children can have both proximal and distal RTAs. So acquired causes of proximal RTA. This is very important because before we embark on doing some genetic testing in these children, we are justified in ruling out the acquired causes. This is more true in adults, but in children also sometimes we can identify them at an early age, because in children, ALL children, sometimes they present to us with renal tubular acidosis, and multiple myeloma is the commonest cause of proximal RTA in adults especially. Sjogren's also in the middle age, especially females and all, when they, as I told you, renal tubular acidosis are systemic diseases actually. So if they have dry eyes, dry mouth associated with these defects, then you suspect probably the child might have underlying Sjogren's disease. And most of the epilepsy patients, childhood epilepsies are common. They will be on valproic acid. So any patient on valproic acid, they have certain features of RTS. Drugs should be suspected. There are many other drugs, but these I highlighted because they play a major role in, especially the acetazolamide also is used by the neurologists and neurosurgeons widely to decrease the intracranial pressure in patients of hydrocephalus. So probably these drugs could play a role, and you should check for these drugs if the child has presentations of RTA with without other facial dysmorphisms or suspicion of hereditary causes. These are the acquired causes of distal RTA, as I have told you: Sjogren's, SLE, and Graves' disease. Medications like amphotericin, lithium, and aminoglycosides. So type 4 RTA, award on type 4 RTA is a primary defect lies in the regeneration of bicarbonate, secondary to lack of adequate urinary ammonia. So most commonly it is acquired. So remember simply that type 4 RTA is mostly acquired, and the causes are very treatable causes. Like if the patient has urinary tract infections or something like posterior urethral wall, reflex nephropathy, pyelonephritis. So remember that type 4 RTA will be referred to you by urologist, because most of these children will be followed with the urologist. Post-operative patients of posterior urethral valve or post-surgical patients of reflux. Now they present to you with some dyselectrolytemia. Then suspect type 4 RTAs. And autoimmune conditions like interstitial nephritis, there are a number of drugs, NSAIDs, ACE inhibitors, trimethoprim, CNIs, though they are rarely used in children, but post bone marrow transplantation, CNIs are being very commonly used. So in that cases also you can see these RTAs. Most of them are reported as case reports following BMT in children type 4 RTAs. So now we have come till now. I have tried to impress upon you the various clinical presentations or the various causes and how do you approach these patients. Now we will go to the management of these cases. So first we will go to the type 1 RTA, that is distal RTA. So here we have seen the predominant defect is acidification defect, but because H plus is not secreted, what is to be important is potassium is completely secreted. We are losing potassium here. This is very important in the management point. So what are the goals? When you treat a child with distal RTA, my goal is completely different. We have to correct the acidosis, prevent the bone deformity, and improve the growth. Because in children, ultimately the parents they do not see the bicarb values or the potassium values. They see my child is not growing properly. His height is not coming, her height is not coming. It will be a problem to them. So these three are my goals. And bicarbonate supplementations. So usually up to 1 year, we give 4 to 6 milliequivalents per kg per day in divided doses. Once thereafter 1 year, we give 2 to 4 milliequivalents per kg per day. This dose should be remembered. And I again remember Hiteshi madam here. I don't know whether madam is here or not. Even in CKD patients, childhood CKDs, I used to write nodosis only for bicarb supplementations. Madam used to write potassium citrate combinations. Madam, what is this difference? Then madam explained me. See, potassium citrate formulations would try to help corrections of both potassium as well as bicarbonate. Then I understood, okay, so seniors prescriptions have lot of meaning to understand. If you don't know the meaning, or you don't know the policy behind it, it's better to ask them, because until then I asked out about that question. Then I understood the importance of writing potassium citrate formulations, especially in childhood CKDs or even in renal tubular acidosis children. Once hypokalemia is corrected, hypokalemia improves with the correction of acidosis itself, but some children might require low-dose long-term supplementation of potassium, which is approximately 1 to 2 milliequivalents per kg per day. So this I have already told you, potassium citrate would help also reduce hypercalciuria in addition to metabolic acidosis, thus preventing the formation of nephrocalcinosis. And most important is, it should be remembered that though you correct acidosis, it is not going to retard the progression of nephrocalcinosis or hearing impairment. This is because this is important in prognosticating the patient, because the parents would definitely ask, okay, we are giving the treatment, but there's no improvement in hearing. You should be able to tell, see, with my treatment, what you can expect and what you cannot expect. Then the child understands that what he is going to get out of your treatment. And regular screening for nephrocalcinosis and hearing impairment must be done, and some other targeted therapy should be given to these patients. So coming to the proximal RTS, here we have seen that the predominant defect is absorption defect, a failure to absorb bicarbonate. So we are going to give bicarbonate supplementation in this particular patients. Here my goal is promote growth as well as prevent the bony deformities. As I have already told you, here we need large doses of bicarbonate, and it's very difficult to correct also in these patients. But the dose is 10 to 15 milliequivalents, whereas in distal RTS it is only 1 to 2 milliequivalents per kg per day. And the potassium supplementation here is 1 to 5 milliequivalents per kg per day. Phosphate is 20 to 40, and sodium is 3 to 5, and magnesium is 25 to 50 milligrams per kg per day. Unlike distal RTS, children with proximal RTS require very high doses of bicarbonate. This should be remembered, and it helps us in adjusting the doses in clinical practice. As I have already told, these are the basic components. When we know, means when we don't know how much is there in that particular component, this is important for practical purposes. In the potted syrup, bicarbonate and potassium are present at 2 milliequivalents per ml. So based on that, we can calculate our doses. And sodamate, it is 3.6 milliequivalents per 300 mg tablet and 6 milliequivalents in 500 mg tablet. And phosphate supplements, several others are available. The most common side effects are when we start giving these syrups, patient will tell the child is having a lot of diarrhea and abdominal pain. Try to counsel them. These things will subside in a few days when you get tolerated to these things. If you stop this, it is going to impair your growth and increase your bony deformities. We are also going to give vitamin D supplementation at the rate of 20 to 40 nanograms per kg per day. So this is the treatment part. I just would like to discuss some of the common causes. Cystinosis, this is very important because this is the one of the causes of proximal RTA, which has a definitive line of management. We have a drug to this. So here you can see that in general, it is a tubulointerstitial disease. And you have the giant nucleocytes of the proximal renal tubule here, as well as podocytes. So giant multinucleocytes are common in this particular disease, and you can see the cystine crystals, polymorphic rectangular shaped crystals, and in the eye, these are the dust-like depositions of the cystine crystals. So take-home point from this is eye examination and hearing assessment is very, very important in our management of RTAs. So type 4 RTAs, the goal of management in type 4 RTAs is only maintain the potassium in normal range, because here I'm not going to worry about the growth or the bony deformities. And the dose is 1 gram per kg per day in 2 to 3 divided doses. Bicarbonate supplement should be administered to correct the acidosis that is present in these patients. And most of the times you should check for the potassium raising drugs. Remove those drugs, almost potassium will be in the normal range, and you should explain the patient about the dietary restriction also. So I thank Almighty with Lord Rama. He might protect us and save us and take us into a very happy new year, coming new year 2023. Thank you so much. I thank the organizing members for giving this opportunity and all my seniors who were there with me for this presentation. Thank you so much.
Thank you, Shiva Parvati. As usual, it was a very wonderful talk. You have covered all the aspects of renal tubular acidosis, including the presentation and when to suspect, the difference between the proximal and distal, and the management part. I mean, you have actually tried to cover the adult part also. Try to briefly cover the adult part as well. So, what I was wondering is, like, by the time patient reaches us, so syndromic diagnosis of renal tubular acidosis is not a challenge, because they come with the diagnosis. As you said, they go to other either pediatricians or orthopedicians. They pick up and they refer to us. I think it's our responsibility to train the physicians or the pediatrician to the RTAs, the parts of RTAs, and refer to us the earliest. And second thing is, as I said, syndromic diagnosis is not a challenge. But etiological diagnosis, that is a major challenge, and we, end up having no etiology most of the times. And now that the availability of the genetic, the workup is there, so my question would be, when do you, ask for this genetic workup? And second thing is, you have also mentioned about the Wilson's disease, proximal disease. They usually present with a combined proximal and distal. So it is difficult. It is easy to pick up whether it's a proximal, distal. Proximal usually present with a mild, and then you challenge, and then distal acidification is maintained. That's why you get a urine pH is low. And in distal, though it is severe metabolic acidosis, because distal mechanism is lost, the urinary acidification doesn't happen, and urine is alkaline. So that is a major difference you can make it. So when do you suspect is a combined, particularly in Wilson's, it's proximal as well as distal?
So first question is, when do you go for a genetic analysis, ma'am? So usually distal RTA patients, we can directly go for the genetic analysis, because most of the times, if you look at the epidemiology, autosomal recessive form is the most commonest form. Once we rule out the drugs and the acquired causes, because ruling out the acquired causes also is easy in these particular patients, because it's Sjogren's, SLE, and Graves, where blood tests are available for them. And the other drugs like amphotericin, lithium, and aminoglycosides, we can rule out them. So in distal RTAs, we can go for the genetic analysis, but usually the patients, they don't prefer to go, because when the treatment is only this, there is no change in the treatment for even after you only establish the diagnosis. This is because of the H plus exchange pump, or this is because of the anion exchanger pump. Rather, they would go for preferring spending that money for correction of deformities, madam. See, sometimes I have right now 3 patients, because the hospital where I work is a predominantly orthopedic hospital. So most of the children, they come for deformities. I asked them, we will go and do some genetic analysis. So distal RTS, we can directly go, but proximal RTS also, most of the proximal RTS like hereditary fructose intolerance or galactosemia, tyrosinase, and cystinosis, they are in the very early presentations, ma'am, in the pediatric presentations only. At that point only, we should have done genetic analysis. In cystinosis, because you have asked, the infantile nephropathic form is the most common form, which is leading to end-stage renal disease. So if we do genetic analysis in that particular part, in this particular patient, it would be helpful for us in the post-transplant phase also. Otherwise, all other diseases, they are helpful for further planning of pregnancy. Suppose if the parents, they want to conceive for another pregnancy, they wanted to know what is the pattern of inheritance, should we go ahead or should we stop this pregnancy. They're more useful in that point of view, madam, rather than for the management or the treatment of the patient. Second one, in Wilson's disease, it is not straightforward, ma'am, whether there is a combination is present or distal is present. Looking at the urinary pH, as I already told you, if the distal is more prominent, if the distal defect is more prominent, the urinary pH is always less than 5.5. It's always more than 5.5. So the patient is not able to acidify, madam. So where the copper is getting deposited, that will decide the patient will suffer whether proximal RTA or distal RTA. So I have not seen till now, I have seen only 2 patients of Wilson's. One patient has distal RTA. The other patient did not have any renal tubular acidosis. Probably we missed because it is a mixed RTA. So I would suggest urinary pH would help us in differentiating, madam.
Well said, Shiva Parvati. As you have explained, I think with the availability of genetic testing, I think we should go for that, particularly for the prognostication. And in fact, there's also emphasis on antenatal diagnosis, and further managing the patient. Okay, any the audience questions?
According to
other panelists.
Yeah, ma'am. Actually, we published data few years back. Most of the distal RTAs are idiopathic in nature. If they are associated with some genetic abnormalities with the channels, usually they might be having some amount of deafness also. So in any distal RTA with deafness, it is preferable to go for genetic testing, but not in most of the other cases. I beg to differ. Whereas in proximal RTA, see, proximal RTA usually does not exist isolatedly. The reason being, whenever there is something wrong with the proximal tubule ATP and energy generation, that comes under a whole bracket umbrella of Fanconi syndrome. And again in primaries, which is very common in pediatric, but as the children grow, when we find some atypical cases, for example in cystinosis or all the secondary causes, definitely genetic testing is mandatory, and it will help in the prognosis also for the planning and the genetic counseling also. Thank you.
Thank you, Vijay, for the inputs.
Thank you, sir, for adding this point, especially if the distal RTS, ma'am, if the patient will have hemolytic anemias, because anion exchanger deficiencies will have associated hemolytic anemias, as Sir already told. Hearing assessment is more common in H plus exchange, H plus pump. So this too will help us in clinically isolating these particular cases, sir. So at that point, we would definitely go for genetic testing. Thank you, sir, for sharing your experience.
I think that was a great presentation and discussion. So I think we can, further, comments are there in the chat box. I would like to hand over to the organizers, Niharika, please. Thank you. Thank you for the opportunity.
Sure, ma'am. Thank you, ma'am. Thank you, Shivaparvati ma'am. That's a very wonderful presentation. Now let us quickly move on to the next session. Development of Kidney and Catgut by Dr. K. Nagajyoti ma'am. And the moderator of this session is Dr. Kiranmai Ismail ma'am, Professor, Department of Nephrology, Usmania Medical College, Hyderabad. Over to you, Kiranmai ma'am.
Hello, hi everybody.
Hi, ma'am.
Thank you, Shivaparvati. That was an excellent session. You have covered everything, very lucid presentation. We now move on to the next presentation by Nagajyoti. Nagajyoti is our own department, very, very sincere and very intelligent, And Nagajyoti is going to present the Catgut. What are the recent advances? What exactly is talked about? Everything is explained by Nagajyoti. Over to Nagajyoti.
Thank you very much, ma'am. How are you, ma'am?
Yeah.
Am I audible, ma'am?
Yes.
Yeah. After a long time, I'm seeing you, ma'am. How are you?
Okay.
Yeah. Murthy garu, slides sharing. Yeah.
So while slides are being shared, I just want to make one comment. So it's very heartening to see, all girls presenting very effectively despite having their personal problems. We could see Shivaparvati struggling with her child, and even Nagajyoti. So that was actually purpose of having this platform, so that they can, freely present despite, having, busy with their kids. Over to you.
Thank you, ma'am. Thank you very much. Slideshow, please. Yeah, next slide. So in this topic, I'm going to cover about development of kidney. Ma'am, am I audible? Hello?
Ma'am, yes, ma'am, you're audible, ma'am.
In this topic, I'm going to cover about development of kidney, prevalence of antenatal renal anomalies or CACUT, clinical presentation of CACUT, diagnosis and management. Next slide. So a brief discussion about our about development of kidney. In mammals, there are 3 kidneys in the course of their intrauterine life: pronephros, mesonephros, and metanephros. Embryologically, all these 3 kidneys develop from intermediate mesoderm. The sacral region of in the sacral region, a pair of ureteric buds sprout from the distal portion of the nephric duct or mesonephric duct or Wolffian duct into the condensing blastema of the metanephric mesenchyme, which you can depict in the adjacent picture: pronephros, mesonephros, and metanephros. The mesonephros is usually close association with the gonads. And in the distal portion of sacral portion of the mesonephric duct, you can see the sprouting of the ureteric bud into the condensing metanephric mesenchyme. Next slide, please. Next slide. Murthy garu, next slide. Yeah. And the tip of the dividing ureteric bud, the ampulla interacts with the mesenchyme to induce formation of future nephrons via mesenchymal epithelial interaction. So several growth factors, genetic disorders, and genes and all interpret in this mesenchymal and epithelial interaction. Now, I'm not going into depth of it. So the tip of the dividing ureteric bud and the ampulla interacts with the mesenchyme to induce formation of the future nephrons via mesenchymal epithelial interaction. In the next slide, you can see this. This is the dividing ureteric bud, and the mesenchyme initially is very loose. Then it forms into a condensation, then a coma shape, then an S shape. Then in the proximal end, you find that a cup appears, and there are a development of vascular plexus, which forms in the glomerulus, then proximal tubule, distal loop of Henle, distal convoluted tubule, and which next slide, please. Murthy garu, next slide.
Murthy garu, otherwise you can give access to ma'am herself.
So this is another slide, another view of predicting the MAT, mesenchymal epithelial interaction. This is a distal dividing bud of distal dividing ureteric bud, condensing mesenchyme, renal vesicle, S-shaped body, then forming into Bowman's capsule, proximal distal convoluted tubule, loop of Henle, and distal convoluted tubule. Then the DCD is condensing into the collecting duct. Okay, so the tubular portion of the nephron becomes segmented into a proximal distal order, proximal convoluted tubule, descending and ascending loops of Henle, distal convoluted collecting system. The collecting system consists of collecting ducts, calcices, pelvis, and ureters is formed from the ureteric buds. So in humans, nephrogenesis is completed before birth at around 32 to 34 weeks. In this, for postgraduates, you should know the source of development of proximal convoluted tubule loop of Henle is the mesenchyme, metanephric mesenchyme. Whereas the collecting ducts, calcareous, pelvis, and ureter is formed from the ureteric, but developing from the mesonephric duct or Wolffian duct. So in humans, nephrogenesis is completed before birth at around 32 to 34 weeks of gestation. The next slide, please. So renal ascent. Renal ascent usually occurs between 6th and 9th weeks. So the next diagram, it predicts about the renal ascent and development of the urinary bladder, cloaca, how cloaca is divided into urogenital sinus and rectal part, and then the development of bladder and urethra also. The entire, the next picture depicts upon the ascent as well as the development of the lower parts, bladder and all. So renal ascent occurs between 6th and 9th weeks. The vesico-urethral canal gives rise to bladder and pelvic urethra. The caudal urogenital sinus forms a phallic urethra for males and distal vaginal tubules for females. Next slide, please. So this is brief introduction of development, and now I'm going to the congenital anomalies of kidney and urinary tract, also known as Hackett. The epidemiology is 30% of all antenatal malformations, 1 in 500 fetal ultrasound examinations constitute Hackett. Congenital abnormalities of kidney and urinary tract are the leading cause of end-stage renal kidney diseases in children. The embryology of kidney and urinary tract is modified by genetic mutations and environmental factors leading to Hackett. Next slide, please. So what is the pathogenesis? Genetic mutations. Many of the genetic mutations are that, but some more common mutations are red signaling, ROBO2 gene mutations, BMP4 mutations, PAX2 gene mutations, and RAS. I didn't go into depth into the genetic mutations because it's too much to remember for anyone. So environmental factors in utero. What environmental factors do play is maternal diet, especially maternal undernutrition, reduced dietary protein, significant reduction in number, causes significant reduction in nephron number and hypoplasia. Vitamin A deficiency during pregnancy also causes renal hypoplasia, and especially a note should be taken on drugs and toxins. AC inhibitors or ARBs. First trimester, they cause renal dysplasia, cardiovascular and central nervous system malformations, and third trimester, they cause renal tubular dysgenesis. Next slide, please. So what are the symptoms and signs? And how the child is going to present it? Hackett. Asymptomatic imaging abnormalities to end-stage renal failure. The child with Hackett can present from asymptomatic imaging abnormalities to end-stage renal failure. So what are the clues in the antenatal period? Severe antenatal oligohydramnios, Porter's syndrome, typical phases with pseudoepicanthus, retrognathia, posterior rotated and flat ears, flat nose, club foot, hip dislocation, joint contractures, and pulmonary hypoplasia. Porter's syndrome usually occurs in severe antenatal oligohydramnios, and it may also present with an abdominal mass, and this abdominal mass may be due to enlarged kidney due to obstructive uropathy or a multicystic dysplastic kidney. A bladder, and these abdominal mass can also be a bladder in a male infant after voiding, such as bladder outlet obstruction, presence of posterior urethral walls, especially in a male infant. Any bladder mass or bladder mass in the distended bladder, usually we suspect posterior urethral walls as a common cause, and it also may occur, and Hackett can occur as singly or as a part of other syndromes. Next slide, please. Then coming to the phenotypes of different phenotypes of Hackett. Aplasia or agenesis. It is congenital absence of kidneys. It can be unilateral or bilateral. Bilateral renal agenesis occurs in 1 per 300 to 10,000 births. An ectopic kidney usually should be excluded when labeling the child with agenesis or aplasia. Then simple hypoplasia. When do you call a kidney as hypoplastic? Hypoplastic means the renal length should be less than 2 standard deviations below the mean for age, and these usually have a reduced number of nephrons. The renal architecture is normal. You don't find any abnormality in the renal structure. They only contain reduced number of nephrons. Then renal dysplasia. Unilateral dysplasia incidence is 1 per 3,000 to 5,000 births. Bilateral dysplasia is 1 per 10,000 births. Characterized by malformation of tissue elements with or without cysts. Bilateral presents earlier with dysmorphism, antenatal hydronephrosis, and postnatal renal failure. Next slides, please. Next slide, Murthy garu. Murthy garu, next slide.
Murthy garu.
Madan,
Please give me the remote. Murthy.
Murthy, just go to the next slide, please.
Otherwise, give me the remote, Murthy. I will change the slides.
I can tap here to control. Okay. Multicystic dysplastic kidney. This is the most severe form of renal dysplasia. On ultrasonography, MCKD is identified as large cystic non-reniform mass. Here the renal architecture is completely lost in the renal fossa. The multicystic dysplastic kidney is non-functional and usually unilateral, as bilateral MCKD is not compatible with life. The complications in this MCKD is, of course, the patient can unilateral multicystic dysplastic kidney. The other kidney is also mildly involved, can present with renal failure, Wilms tumor, or adenocarcinoma. Next slide. Next slide.
Murthy, next slide, please. Madan? Or
so, renal ectopy. So this results from the disruption of the normal embryologic migration of the kidneys. It can be simple, that is non-fused or fused form. So in a simple form, kidneys that fail to ascend normally and remains most commonly over the pelvic rim or in the pelvis, that is pelvic kidney. In renal fusion, a portion of one kidney is fused to the other. Cross-renal ectopy is a condition in which kidneys cross the midline. These are the various forms of renal ectopy. So bilateral cross ectopia means both kidneys or ectopic can cross the midline. So ureter of the ectopic kidney maintains its normal insertion into the bladder, and the ectopic kidney is usually positioned inferiorly to the contralateral kidney. So these are the diagrams which shows the different forms of renal ectopy. Next slide. Then coming to horseshoe kidney. This is the most common fusion anomaly. Symmetric horseshoe kidney means the isthmus, that is fused portion, lies over the midline. Asymmetric horseshoe kidney means it is the fused portion is present a bit lateral to the midline. In greater than 90% of the cases, lower poles are fused with upper poles separate with two ureters. It is usually found in pelvis or at the level of L4 or L5. Some develop urinary tract obstruction, loin pain, and hematuria, and urinary tract infections, urinary stasis, VUR, and calculi. Next slide, please. Next slide, Murthy Garu. Next slide. The duplex kidney. Then this is a duplex kidney. Seen in 0.7% of the normal adult population, 2 to 4% of patients investigated for urinary tract symptoms. Complete is duplex major, or partial duplication is duplex minor of the renal collecting system is most common congenital anomaly of the urinary tract. This results from partial or complete duplication of the ureteric bud. This is complete ureteral duplication. The ureter of the upper pole moiety is opens inferior to the ureter of the lower pole moiety. Next slide, please. Next slide, please. Murthy Garu. So this is isolated dilatation of renal pelvis or ureters, or both, is an important manifestation of catgut. This is can be UPJO with or without megaureter, VUR, or PUV. So it can present in 4 forms: UPJO with and without megaloureter, VUR, and posterior urethral walls. Okay, the first picture depicts about UPJO with megaloureter. The second one is UPJO. The third one, the PUV and VUR. Next. These are the grading of the dilatation, grade 1, grade 2, grade 3, grade 4. Management of catgut. So antenatal diagnosis. Ultrasonography is the most common mode of antenatal diagnosis. Fetal renal length. So the fetal kidneys can be seen at 12 to 15 weeks of gestation. These are the normal findings in the ultrasound, normal kidneys in the antenatal ultrasound. So corticomedullary differentiation should be seen by 25 weeks of gestation. Urine-filled bladder is normally identified at 13 to 15 weeks of gestation. And ultrasound examination should be done at 16 and 20 weeks of gestation for diagnosis of catgut, which gives a sensitivity up to 80%. The bladder wall is normally thin. A thick bladder wall suggests urethral obstruction. Volume of the amniotic fluid with fetal urine production begins at 9 weeks of gestation and is a main source of amniotic fluid by 20th week. Oligohydramnios beyond 20 weeks of gestation is a strong indicator of bilateral renal anomalies. Chromosomal analysis by CVS can be done at 8 weeks of gestation. Next slide, please. So antenatal approach, this slide predicts an approach for antenatal hydronephrosis. How frequently should we be screened? Unilateral hydronephrosis, ultrasound in third trimester and postnatal ultrasound at 3 to 7 days. Bilateral severe hydronephrosis, serial antenatal ultrasound every 4 to 5 weeks and a postnatal ultrasound. Systemic malformation, if there is a presence of a systemic malformation and additional soft sign, this child should be, the mother should be referred to a specialized center to rule out malformations in other organs, genetic analysis, as well as to rule out any syndrome. Next slide. So antenatal, is there an antenatal role of antenatal intervention? Surgical interventions like bladder amniotic shunt with obstruction below bladder neck is possible in asymptomatic phase if renal function deterioration is likely. Intervention in utero is aimed at relieving urinary tract obstruction, promoting pulmonary development even in presence of urinary tract obstruction and oligohydramnios. It is unclear if relief of urinary tract obstruction in utero prevents the development of associated renal dysplasia or renal scarring. Next slide. Postnatal management. Indication for imaging in the postnatal period. Bilateral renal malformation or a solitary malformed kidney, abdominal ultrasonography is recommended within first 24 hours of birth. If there is anything which is bilateral or a solitary malformed kidney, immediate abdominal ultrasonography is recommended within first 24 hours of birth because decompression of bladder may be required. If there is an unilateral lesions, then postnatal ultrasound 3 to 7 days can be done. Next slide, please. So this is a postnatal ultrasound. Initial scan in the first week, repeat scan at 4 to 6 weeks. So initial scan in the first week, no hydronephrosis. Society of Fetal Urology grading 0, APD less than 7 mm. So if these criteria are present, no follow-up, no intervention. Suppose the child is having mild hydronephrosis without ureteric dilatations, SFU grading 1 to 2 and APD 7 to 10. Then ultrasonography repeated 3 to 6 months until resolving. Suppose if a child is having moderate severe hydronephrosis, SFU grade 3 to 4, APD greater than 10 millimeters or mild hydronephrosis with ureteric dilatation, go for MCUG. So no vesicoureteric reflex, go for a DTP renogram. Not obstructed, repeat ultrasound at 3 to 6 months with resolution. Obstructed pattern, surgery is indicated based on the surgical indications. DTP renography is used to is indicated to rule out other causes of obstruction like PUJ obstruction and all. Then if vesicoureteral reflex is present, then it's a separate topic. Management of UR is a separate topic. We consider continuous antibiotic prophylaxis up to 1 year of a child and then follow up the child if she in the up to 5 to 6 years. Then if there is any lower urinary tract obstruction in MCUG, then the child should be referred for surgery. This is the nomogram for the postnatal follow-up and management of the child with antenatal hydronephrosis. Next slide, please. Assessment of renal function. The serum creatinine concentration should be measured after first 24 hours after birth. Declines to normal values 0.3 to 0.5 milligrams within 1 week in full-term infants and 2 to 3 weeks in the preterm infants. Control of hypertension and management of recurrent UTI forms an important part of treatment in the postnatal period. Next slide, please. Murthy garu, next slide. So renal dysplasia, multicystic dysplastic kidney. Renal ultrasonography is recommended at an interval of 3 months for the first year of life and then every 6 months up to involution of the mass or at least up to 5 years of age. Voiding cystourethrogram should be done in all patients with renal dysplasia even in absence of hydronephrosis. Technetium DMSA scan, which concentrates only in healthy renal tissue, provides information on differential function of each kidney. Next slide, please. This is a take-home message. In a CACT, treatment requires correction of anomalies and treatment to retard the progression of CKD. It requires an establishment of collaborative framework among multiple centers throughout the world is required to unravel the genetic basis of CACT and provide precise genetic counseling for CACT patients and their relatives to enable personalized medical care based on the detailed understanding of the molecular pathogenesis of the disease. Thank you.
Thank you, Nagajyoti. It's a comprehensive. You have covered everything, and the diagrams were very self-explanatory. Thank you very much. I just
Thank you,
want to ask you, do you recommend routinely genetic analysis for these patients of their family as well? When do you recommend actually? If at all you
Madam,
want.
most of the CACT patients, underlying genetic mutations are known to cause a CACT, madam.
Yes.
But nothing much can be done in the present patient. But if they want to know the recurrence in the future pregnancies, the inheritance pattern and the probability of the other child getting infected, then we can go for genetic analysis. In the initial child, if you want to go for a genetic analysis, especially to rule out a syndrome associated. In the current child, if it is whether syndrome associated or not, we can go for CVS sampling at 8 weeks, madam. If the CACT is isolated or associated with any syndromes.
Many of the CACUTs are actually asymptomatic, predominantly.
Asymptomatic, predominantly. Only if antenatal screening, if you find any abnormality, and if you are suspecting the abnormality is related with any syndromes, then we can go for severe sampling at 8 weeks, madam. Only in severe forms of CACT, not mild forms of CACT.
Yes. So of late, many of the females are going for a late conceptions and especially the in vitro fertilizations, and CACUT has been reported in such cases also. Do you think you have to routinely offer any antenatal genetic analysis for such cases? Because
no, ma'am. I don't think it's cost effective or I don't think it. So in vitro fertilization, if even if there is any in vitro fertilization as such, I don't recommend it unless they had a family history of CKD or any family history of CACT in their generations. Routine IVF, I don't think we need to go for a genetic analysis in each and every patient unless we find any abnormalities in antenatal ultrasound.
Thank you, Nana. That was an excellent presentation. Happy to see you all, and we will presentation. I know you will completely spellbound us. Thank you so much.
Thank you for your kind words, madam, on appreciation. Thank you very much.
Thank you, Niharika. Shall we move on to the next session, please?
Yes, ma'am. Thank you, Nagjyoti ma'am, for a wonderful presentation. Now we are moving on to the next session, nutrition and immunization in pediatric kidney diseases by Dr. Vijay Kiran sir. Actually, this session should be moderated by Dr. Manisha ma'am, but as Manisha ma'am is not available, I request Kiranmayi ma'am to chair this session.
Yeah. Thank you, Niharika. Manisha could not chair this session, but I will be doing. And actually, it's a very big series, Dr. Vijay Kiran. But
good evening.
He is very, very long. But I know he's a very brilliant nephrologist. I happened to assess him in the exam itself. He's a brilliant nephrologist, very passionate about his teaching, and he has acquired many degrees even after his DM also. Today, he is going to present nutrition and immunization in the pediatric population. Please go on, Vijay Kiran, just start the presentation.
Yeah. Thank you, ma'am. I would like to share my screen so that there won't be any miscommunication. Just give me a moment. So, Mr. Murthy, are you presenting or should I share it? I would prefer to share it. So, yeah, can you see it now?
Yes, sir. Slides are visible, sir.
Complete full screen or half screen?
No, sir.
Full screen?
Full screen inka raledu, sir.
Yeah.
It's a half screen only.
Correct. Can you see it now? Full screen?
Yes, sir. Yes, sir.
Yeah. Thank you. Good evening, ma'am. Kiranmayi madam was my DM examiner. Good evening. Thank you so much, ma'am, for the invite. Jikki ma'am, we all know, everyone in both Telugu states know about Jikki ma'am, and we are very honored to have her here. Swarnalata madam is my guide and my senior, and whenever I have any trouble, I just go and meet her. And everybody knows about Hiteshi madam also. and all my juniors, Niharika and Pavani. Pamari was my junior in my MD days from Tirupati. I did my MD from Tirupati. So I know all of you guys. And now, after these two presentations, which were like a roller coaster ride, I'm afraid whether you people will like my presentation or not. Okay. So please bear with me. Please bear with me if I do any mistakes. But learning is a constant process. I understand and I will improve. So I will be talking about growth retardation in chronic kidney disease and how to assess this growth retardation and what is the solution for the malnutrition which we see in these children, and some slides about the immunization. The reason why we are supposed to talk about this topic is that because children are not miniature adults. We all know this. This is a dictum. Every pediatrician knows it. You must have seen these Flipkart ads where children are dressed up with gray hair and like they're mimicking adults. But the same situation is not there in in reality. Children, the data which is there in adult nephrology cannot be generally extrapolated to the pediatric age group. They have a completely different physiology. Just try to imagine that a newborn child's GFR is not equivalent to a GFR of an adult. So in the same way, the maturity of the tubules, the glomeruli, and the urinary maturity is not at all there in the newborn and even in the children. So it is illogical to extrapolate the data from the adult to children, and hence we have to understand that we need more rigorous data points. Now, I have recently started little amount of gardening, and then I was observing when we plant a tree, for it to grow and for it to grow properly without any hindrance and bear fruits, it requires some elements from the nature, both sunlight, oxygen, carbon dioxide from the air and the sun, and from the ground it requires water and all the other nutrients. If all these things are there in equal and a balanced manner, then the growth will be normal or in fact very good. The same thing can be seen even in children. So growth is usually largely contributed by nutrition. We all know that. But sometimes growth has got some more factors which affect this. Okay. And this we usually tend to neglect in our busy clinical practice, because as we see a patient, first thing which comes to our mind is what is the diagnosis. Second thing is what is the solution. Third thing is what are the medicines, what is the dosages, and when to follow up. That's all. But some nuances, some subtle things which are very, very important is growth and nutrition. So nutrition will only work when the internal milieu is optimized. So if internal milieu is not optimized, that is the urea, creatinine is high, or there is acidemia or acidosis, and there is anemia, you just can't start on growth hormone. First, you have to address all the deficiencies, and then only you have to think about a very higher and sophisticated treatments. For example, when do we start growth hormone? Usually growth hormone therapy usually works when the supportive measures are adequate and optimum. So what are the supportive things for a child to grow normally, to grow optimally in a CKD milieu? That is, nutrition has to be taken care of, which is the topic of today's discussion. You should be given feeds either in NG tube, gastrostomy tube, or nasogastric tube, and other components like which I was mentioning, bicarbonate, CKD, MBD, anemia. If they are not addressed, the overall comprehensive growth of the child will never occur. Other things we have to keep in mind that the definitive treatment for any child for growth retardation is renal replacement therapy, no doubt about that. At the same time, we have to keep in mind that any glucocorticoids which you are giving, which we use left and right in adult nephrology, we have to be very careful either in tapering them down or putting on an alternate day therapy so that they won't hamper the growth of the child. And third would be the recombinant human growth factor therapy, which, as I told, should only be your last resort, not the first one. So when the height of the child is not growing, and when the child by definition is less than third percentile, then earlier the better that we start growth hormone therapy, but do keep your targets in a very conservative way. Usually there won't be more than 2 centimeters growth per day per annum in growth hormone therapy. So these are the usual children which we are dealing with. CKD, ESRD, either on hemodialysis or peritoneal dialysis. These patients are cachexic, anemic, they have got a lot of hypercatabolic state. These are the things which you have to keep in mind. Now let us try to understand why such amount of protein energy wasting occurs. Because first thing is, as the blood moves through the extracorporeal circuit, it causes a sort of inflammation, cytokine storm. This leads to active or increased catabolism, number one. Second thing is, there will be definitely loss of amino acids which occur through the dialyzers. Third thing is the altered microbiome. This latest concept of gut dialysis has cropped up, which says that our gut microbiome also influences the uremic milieu of the patient. Fourth thing is the food insecurity, especially seen in our country and third world countries. Decreased appetite due to various other factors, reduced ghrelin, increased leptin, and all these extra cellular cytokines released in dialysis can also contribute. Uncontrolled metabolic acidosis and the uremic milieu all lead to this protein energy wasting. And this usually progresses as the stages of chronic kidney disease progresses. Okay, we have to understand this. So the malnutrition causes are, one, as I previously discussed, it is poor appetite. Second thing would be decreased intestinal absorption of nutrients. Third thing would be metabolic acidosis affecting the physical growth and also neurocognitive development of the child and overall fragility also. So now let us look at some of the statistics. Growth stats in CKD has been shown that by CKD stage 5, that is by the time they are less than 10 GFR, nearly 25% of the children are below the expected height. And this keeps on increasing as the CKD progresses. So poor nutrition is not the only reason. Other things could also be contributing. This is what we were talking about. A patient comes with malnourishment, poor growth in CKD. You just can't jump onto providing extra calories, extra proteins, all those things. You have to have a holistic approach. Try to look for other reasons, like we were telling, IGF growth hormone and recombinant growth hormone therapy. All these things have to be kept in mind. Not only height, weight loss is also very, very significant. Weight loss primarily occurs when the GFR gradually decreases less than 35, and this weight loss has been associated with higher risk for renal function itself. So it is an independent contributing factor for increasing loss of residual renal function. So how do we assess? So these children require more frequent assessment. If a normal child of 2-year-old will requires certain assessment, these children should be subjected to twice the amount of assessment. So what are the things which we look for? Just a moment. We look for, in infants, when to monitor is 2 to 6 weeks. So what do we monitor? We look for the weight for the length and head circumference with Z scores. In 1 to 3 year kids, every 1 to 3 months, we have to keep monitoring all these things. More than 3 years, at least monitoring once in 4 months is what we usually practice. Weight, height, BMI, and growth velocity, the previous speaker was talking about, our growth charts are the very, very basic and very important. And those children who are on dialysis, all these things have to be monitored monthly. So why is it important? It helps in diagnosis of the growth failure immediately or in the earliest fashion. And because for every decrease in height by 1 standard deviation, mortality usually increases by 14%. And in this multicentric CKD-I study, it has been shown that short stature in children with CKD was found, and those who gained height had a better quality and health of life. So treatment is, as I told you, optimization of internal milieu. This is the first. Second thing is energy. Third thing is protein. And fourth thing is the other supportive vitamins and minerals. So when we are defining energy, how much is required to be given, we usually say in the form of estimated energy requirements. Okay, and further supplementation is only needed when this usually fails. So even in adults, when we are assessing the caloric requirement and protein requirement, we talk about what is called as ideal body weight. So a patient who is on dialysis is 30 kg adolescent boy. We do not give calorie and protein for that 30 kgs. We have to provide calorie and protein estimation for his ideal body weight. That is, for that age and sex matched, age matched, that weight for that target, we have to give the supplementation. The preferred route is always oral, no doubt about that. But sometimes what happens is these children some children are more fussy, difficult to feed, and may not be compliant, obviously, because they are children. So in those children, gastrostomy tube, transpyloric tube, or even a basic nasogastric tube feeding has to be started, or else you cannot provide the adequate required kilocalories, and growth won't be sufficient. And if growth won't be sufficient, because basically what we are trying to look is to bridge the gap between the chronic kidney disease CKD stage 5 and the transplant. And transplant will only be successful if at least the weight of the child is between 12 to 15 kgs. Less than that, it will be a technical challenge. So we have to keep that in mind and be little more aggressive in the treatment of this energy deficiency. Okay. Some trials have also been done for intradialytic parenteral nutrition therapy, especially in those children who are little adolescent and adults, and in them we can give intradialytic total parenteral nutrition. It has been found to be beneficial. So estimated energy requirements, these things are available online. You need not have to by heart all these formulas. Whenever you get a child, you just get the growth charts and look at the peer weights, and then for that peer weight, try to calculate how much amount of deficiency is there. For doing all these things, we should and we must always take a teamwork, and we should, I emphasize that if you are having a renal dietitian and if she is having some amount of pediatric experience, then that will make a lot of difference in your clinical practice. So try to gain that skill set in your renal dietitian, or get somebody who has got already experience in these things. Coming to the protein supplementation, in CKD stage 1 to 3, it's nearly 100 to 140% of age and gender, like I said, ideal body weight, not the present body weight. And as the CKD stage progresses, it is 100 to 120%. The routine low protein diet, which we usually follow in adults with chronic kidney disease, especially in diabetic proteinuric chronic kidney disease, to retard the progression of chronic kidney disease, that is usually not followed in children, because here we are not only aiming at renal health, we are also aiming at the general health and the nutritional and height of the child. So for patients on CAPD, the protein intake should be furthermore increased, because we have to keep in mind the daily losses which are occurring in the CAPD. So protein supplementation should be considered, and enteral protein intake, if it is inadequate, can also be increased. So protein restriction, which I was talking about in adults, is usually not practiced. So these are the recommended dietary protein intake in children with chronic kidney disease, based on the age group, based on the CKD stage 5, based on hemodialysis, whether they are on peritoneal dialysis. These are all the recommended protein intakes. The maximum is for those patients who are on CAPD, because there's a lot of protein loss in the CAPD fluid that has to be fulfilled. Now coming to vitamins and minerals, these are a must. Almost 100% of the daily requirement has to be given. Thiamine, riboflavin, pyridoxine, and all have to be replenished. And even the micronutrients like copper and zinc are also very, very important. Vitamin D deficiency is very common in children, especially with chronic kidney disease, and this has to be monitored and corrected. In children with advanced chronic kidney disease, the metabolism, that is the clearance of fat soluble vitamins, especially vitamin A, is very, very less. So there is a chance of hypervitaminosis A. So only give vitamin A if the document levels are low. Otherwise, do not try to replenish or overtreat with vitamin A. To summarize the nutritional aspects, a skilled pediatric dietitian will be a very, very useful tool. Try to optimize nutrition and uremia and anemia and acidosis even before contemplating growth hormone. Growth hormone is not the panacea. I have seen people jumping onto starting growth hormone, especially in bigger corporate hospitals, even before they optimize the internal milieu. Trust me, it's not going to work. And every child is different. We have to try to identify the child's requirements and needs. Some children, even our own children, look at our own normal children. They are so fussy. They don't eat this, they don't eat that, they only want that. Now just imagine on top of it, these children are having chronic kidney disease. And then what will be the status or the stress to the mother? In infants, breast milk is the feeding of choice. And if low potassium or low phosphorus intake has to be given, then think about a supplement. Don't hesitate to go for tube feedings. This is a very important thing which you have to remember. If in a child who has not been introduced to sodium, it is better to just continue, better not to add any salt in the diet, and try to just remember about the invisible salt sources. So what is an invisible salt? We all know that while cooking, we add some salt. But during manufacturing processes of certain foods, there is intrinsically salt which is added, which we do not tend to recognize. So labels should be read properly. Any junk food like all this kurkure, chips, cheese slices, bakery stuffs should all be avoided. And especially children are fond of this ready-made soups, and ready-made soups have also very high salt content. That is number one. So no processed foods. There is no role of salt substitutes. You all must be aware of this Tata low salt, salt. Okay, low sodium salt. Do you know to maintain the saltiness, or what they do is to, when they reduce the sodium, they increase the potassium. I have seen a patient who had severe hyperkalemia, and I was not understanding why he had hyperkalemia. And suddenly when I asked which salt they use at home, they told me that they are using this low sodium salt. So try to emphasize this point to the parents and try to ask them, because chances of hyperkalemia will be little higher, especially in GN glomerulonephritis, FSGS, where we already start the patient on enalapril. Again, the chances of hyperkalemia will be there. So please keep all these things in mind. And flavors or spices can be added to increase the taste of the food. Taste of the food is not based on salt. Try to remember that. Salt is just an addictive agent. It does not reflect the taste. Okay. And try to avoid pickles, chutneys, cheese spreads, and all these ready-made soups in children with chronic kidney disease. Coming to potassium, encourage breast milk as it is low in sodium. Potassium is a food which cannot be tasted. So kindly read the labels which the child is taking. Avoid ready-made fruit juices, and introduce the concept of leaching in these children if they are prone for hyperkalemia. I'm not talking about salt-losing nephropathies in those children with nephroptosis or those with already having hypokalemia. I am talking about glomerular disease, CKD, CG and CKDs leading to hyperkalemia only on enalapril or telmisartan. So introduce the concept of leaching. There's another concept of double leaching also. Kindly read about that. Ultimately, the amount of potassium through the diet has to be reduced. And these potassium-rich foods like bananas, dry foods, potatoes, tomato products, ketchups have to be avoided. No chocolates. Okay. See, right from our childhood, we tend to get confused between chocolates and candies. Okay. Chocolates is which is from the cocoa fruit. It has got high potassium. Whereas those sugar candies which we get most of the times without any cocoa powder are filled up only with sugar syrup and water, and that's all. So if a child is cranky, is not eating properly, and has to be given some treats to train, we can use those candies. Okay. Candies are not chocolates, mind you. And be careful with the ice creams again, because ice creams have very high salt content in them. If you have to, if you order ice cream next time, kindly read the label if they provide. It has got very high salt content. Coming to the vaccination which is required in these children. So pre-organ transplant, let us divide into pre-organ transplant and post-organ transplant and some other like nephrotic syndrome conditions. So if a child is pre-organ transplant, is on dialysis, and they are contemplating to undergo a transplantation, then they should receive all the vaccinations according to the schedule. Okay. So if they do not have all of the vaccinations, it is better to postpone the transplantation date and complete the vaccination schedule, and then only go for kidney transplantation. So these schedules are widely available. They are published by various societies, National Kidney Foundation, and many other European societies have their own transplantation vaccine or CKD vaccination schedule. So hepatitis B, DTP, HIP vaccine, IPV vaccine, polio vaccine is oral polio is live vaccine, can only be given pre-transplant. MMR vaccine can only be given pre-transplant. Varicella vaccine, again, these are 3 live vaccines which have to be given pre-transplant. You cannot give them post-transplant. Please keep that in mind. So if the child is completely vaccinated, then you can directly continue. If the child is not vaccinated, first get him vaccinated and then contemplate kidney transplantation. What about vaccines for other children in the household? For example, this child is undergoing kidney transplantation, and there's a sibling who is supposed to receive the vaccine. Okay, then we have to keep in mind that these vaccines, especially varicella, is a live vaccine, and there is a probability of transfer of this virus. So this child has to be separated from the immunocompromised child. However, other vaccines like MMR can be given to the other siblings, not to this sibling who has undergone transplantation. Now, post-transplant, or the child is on full dose of steroid, especially for nephrotic syndrome, we usually avoid vaccinations, and if at all required, only inactivated vaccines have to be given. Live vaccines are strictly contraindicated. So what are better not to give is MMR, varicella, and oral polio. Instead of that, we can go for injectable polio vaccine, or in these children, if they are on alternate day steroids and are in the tapering schedule, you can go ahead and give vaccination. Now, a small food for thought: a 5-year-old child with nephrotic syndrome on full dose steroids, first episode. Okay, now he had a street dog bite. Okay, so what will you do? The child has already been started on steroid. He is on 3rd or 4th week, full dose, 2 mg per kg. He has a dog bite, street dog bite. Now what will you do? Any of you? Or should I proceed?
Yeah, proceed, Vijay.
Fine, no problem. See, rabies vaccine is again inactivated vaccine. So no doubt about that, you have to give it. So this comes under post-exposure prophylaxis. And the same schedule has to be recommended by WHO of 5 doses have to be given. But do keep in mind that you have to observe the dog for the next 10 days. So it is an inactivated vaccine. You can give it. It won't cause any vaccine activation. It won't cause it vaccine-induced rabies because there's nothing like that. But what you have to keep in mind is that adequate antibody response may not be there, and a prolonged treatment, prolonged vaccination schedule may be required, and the dog has to be observed. So in a case of nephrotic syndrome, okay, a child with nephrotic, what are the vaccines we give? If the child is in remission, normal vaccination schedule can be given. When the child is in relapse and is on therapy, especially with steroid resistant cases, this we have to keep in mind that we have to keep in mind that we do not go ahead with these live vaccines, whereas inactivated PCV, annual influenza, recombinant vaccine, the particulate vaccines, HBV, meningococcal, HPV can all be given, even COVID vaccine. Okay. So another question which we may like to ask is, can vaccines cause kidney diseases? Because we are dealing with kidney disease and vaccination is a topic in mostly predominant to children, but also in adults, but mostly to children. So shall we ask a question which is other way around? Can vaccines lead to kidney diseases? Yes. There have been many documented cases of influenza leading to nephrotic syndrome, rhabdomyolysis, post-immune GN, and post-transplant graft rejection. Hepatitis B, we all know that it can lead to nephrotic syndrome. Even membranous nephropathy also, lupus nephritis. Pneumococcal can lead to all these things. So these are the various things which we have to keep in mind, that vaccines can also sometimes lead to renal dysfunction in the form of various, the whole list which is here. With this, I would like to thank all my friends for your patient hearing. Thank you, ma'am.
Thank you, Vijay. That was a very informative lecture. Thank you very much. You have comprehensively covered everything. And I have a query actually. You were presenting the vaccines to be given in nephrotic syndrome and all. So suppose a patient comes with a relapse and he's due for his boosters. What do you advise such? This is a common question we encounter with the pediatricians as well as the general public. So how do you go about it?
First things first, ma'am, we have to identify which is more important. If the child is in relapse and he's having the edema and he's having severe proteinuria, obviously that takes the upper hand. We have to treat when the child is on full dose steroid, 2 mg per kg. Treating nephrotic and bringing it into remission is more important than vaccinations. But once the child is on alternate day dose steroid and in a decreasing dosages, we can go ahead. The problem is not with vaccination. The problem is with immunogenicity of the vaccine.
Exactly. Okay. We have a question in the chat box. Pavani wants to ask, what is the dose and duration of growth hormone, if necessary, after optimizing internal milieu?
Yeah. So growth hormone should always, we have to keep in mind that there are two areas, two focal points where we start growth hormone. When your Z score is less than 1.88, that is the height velocity, or basic thing is your height is, the child's height is less than third centile. Earlier the better we start, and the dosages, what they usually say is up to 4 units per meter square has to be given, and this has to continue for a long duration. But our targets, what we are expecting is, what we should be anticipating and looking at is at least 2 centimeters of growth per year, and then only we can call it as a successful growth hormone therapy and then continue it. Obviously, there are many caveats here. You have to keep in mind that the epiphyses are not fused, because there's no point in giving growth hormone because they won't grow when the epiphysis is fused, number one. Like other internal milieu, which I was telling, which I keep on telling the reason, because it's subtle, even in the subtle manner also, acidosis will definitely affect the efficiency of the growth hormone. It is a costly therapy. It is a long-term therapy. It has to keep on, you have to keep on giving subcutaneously injection daily. It has to keep on going. And the futility is just 2 centimeters per year. No, you have to balance the cost and the effectiveness to the everything, and then only go forward.
Okay, we have another question from Saivani. Vaccination in nephrotic syndrome who has received rituximab.
Who has received rituximab? Yes. So when you look at this slide, if it is visible to you, therapy with monoclonal antibodies CD20, this is rituximab. At least 6 months should be there before we contemplate vaccination, whatever form of vaccination be there. Because as you know that it's a complete patient is completely immunocompromised. Even if you give that vaccine, there won't be any immunogenicity. Even if it is there, also you cannot document it.
Okay. No
So
more.
thank you. I mean, just a comment from me, Vijay. I joined late in half of your lecture, but excellent presentation and
Good
a very
evening, ma'am.
relevant point. Very relevant points you've raised. And I mean, about the vaccination, about nutrition, about not restricting the proteins in children. So not restricting the energy in children, unlike in adults where we restrict the proteins as well, whereas in children should not be restricted. So I think it's an area which we most often neglect. So I mean, thank you for bringing out the excellent points and regarding the vaccination as well. So you have explained very nicely. So only thing is, I think what about like in adults, we use the SGS scores and I mean the other nutritional scores. So what would you advise using in children for objective assessment of growth? So would the scores still apply in children as well?
Yes, ma'am. When we look at the various aspects, for example, since we are talking about an umbrella of diseases, especially in renal tubular acidosis, we can utilize the Z scores to look at the catch-up growth and all those things. In chronic kidney disease per se and malnutrition, it is no more different from the standard SDS scores of the IAP growth charts. Those can be utilized to assess these children.
Like SGS scoring in children as well, the same parameters, the subjective global assessment and the MIS scores and all. I mean, do you use them in children as well, even MIS also?
I'm not aware of that, ma'am.
Okay, fine. Okay, thank you. Excellent presentation. Thank you very much.
As a disclosure, ma'am, I would like to tell that I am an Eklavya Shishya of Manisha, madam. And I would like to thank her for all the comments.
Alright, please, Dr. Vijay, you are embarrassing me. I mean, we have been following your work and it's so nice that you have concentrated on pediatric nephrology and you are doing a great job. So please keep up the good work. It's really very good and such sort of interactions are very good and I think they should increase in future. We can have case-based discussions, all those things, I mean, including you as part of the panel. So thank you. I mean, it was a great talk. Thank you.
If there are no more questions, we would like to wind up the session. Niharika, we don't want to actually extend the session. All of us are waiting for the final, FIFA final. So we are going for the next session. Thank you.
Thank you, ma'am. Actually, I would like to thank all the speakers for their very informative sessions. Now I request Saivani ma'am to give her the vote of thanks.
I deem it a great honor and privilege to propose the vote of thanks on this occasion. And first of all, I would like to thank the Almighty for making these webinars a grand success. I would like to thank my teacher, Dr. Jikki Madam, who is there behind me for organizing all these webinars. And I take privilege to thank the speakers who accepted my request, Dr. Vijay Kiran sir, Shiva Parvati, and Nagajyoti Madam, who is my junior at Osmania. And I thank all the moderators, Manisha Sahai Madam, Kiranmai Madam, and Swarnalata Madam, who accepted my request. And though they are having busy schedule, even on the Sundays, they have accepted me. And I would like to thank Shantiram Medical College for sponsoring these webinars. And I would like to thank this video technology, Madan, for preparing the links and web in flyer invites, even though I have given them the small time, only one day after preparing all the speakers and moderators. And at last but not the least, I would like to thank my family members for supporting me doing all these webinar symposium, because it takes hectic thing with accepting, requesting all the speakers, moderators, and organizing the session.
So I thank one and all for giving me this chance. Thank you.
Thank you, Saivani. Thank you for the opportunity. As
Yourself.
usual, Saivani is very, very modest, very hardworking. Thank you very
Yeah.
much. And Isi Bahane, we met everybody. Thank you.
Thank you,
Thank you.
madam. Thank you.
You have always been a dynamite student, and you are continuing that dynamism. So you are the dynamite of knowledge, and thanks massive.
Thank you.
I learned all these things from all my teachers, Madam Manisha, Madam Jikki, Madam, and Kiranmayi, Madam.